Hi, seniors. This is Dr. Ang coming in. It's my honor and privilege to bring you a quick overview of pediatric nursing specific to NCLEX preparation. So hopefully you are feeling strong, feeling confident in this endeavor of studying for the NCLEX, and knowing that you've been through a rigorous program and looking back and how far you've come. I know that you have all of this knowledge tucked away. I just want to try to bring some of the pediatric content back to the forefront and give just a brief review. If any aspect of this you want to take a deeper dive into that content, feel free to reach out to me. Text, call, email, stop by, whatever. I would love to meet with you. Again, I'm not going to get into this. Again, I've sent you a video and I try to tell each of you if I have the pleasure of running into you, but thoroughly love your cohort, love your group. I'm going to miss you guys, and the future is so bright for each of you. I have something that I can easily think of very positive of your strengths for each of you that you're going to bring out into the profession, and want to be the first to welcome you to the profession and as my colleague. So welcome you, and just know the goal is to not only pass the NCLEX, but to pass it on the first try. So that is why that I want to be here to support you in any way that I can help meet that goal. So let's dive in. I've been told this is to be a very quick overview, so I'm going to get in as much information as I can. So NCLEX, again, we're remembering when it comes to pediatric content, we are looking at everything from birth to adolescence. So we got the newborn, we got the toddler, we got the preschool, we got the school-age child, and then the adolescent. We have all encompassing into the pediatric client. Again, next I'm referencing the PowerPoint that you have available. Dive into that if you want to follow along, or you can just kick back and listen. Objective is not only, again, to pass the NCLEX, but to get it on the first try and to hop in with both feet to your dream job very quickly. So we want to get this behind us and get those credentials behind your name. What is different about kids? Are kids just small adults? No, they're not. There is a vast difference between a newborn that you may encounter in the NICU and an adult patient. And although as we move through the scale and as we move through the ages and the stages of pediatrics, the closer we get through adolescence, we can begin to treat a late adolescent young man as we would into a young adult. Size-wise and things will be much more similar. But when we're thinking specifically of newborns, when we're thinking of infants, toddlers, preschoolers, and even those early years as we creep up in school age into adolescence, it's very different. In what ways, how are kids different? There's difference in developmental stages. There are difference in medications and how dosages apply and are received by, let's say, a newborn and then an adult. There are differences in the way they respond, in the way that they heal, and also in the way that we educate them, on the ways that we just approach them in general. We're not only, for a child, we're not only looking at the child, as we should be with adults as well, but more so in peds, we are definitely educating not only that child in a developmentally appropriate manner, but also the caregivers that are going to be implementing and overseeing that care when that child goes home. So also difference in, let's say for the sake of a newborn, heads are much larger. They haven't fully grown into their proportionate body type. Larger BSA vital signs are very different than that of an adult. And specifically with this, you want to know the norms and the abnormal values, and then for which stages that you're considering. If you see a set of vital signs and you're asked which stage that would apply to, can you do that? That is going to be specific. One of the cardinal signs that you're almost guaranteed to get on the NCLEX is going to be a question similar to that. They're more prone to lung and respiratory concerns. And why is that? They have smaller airways. They're less stable for their necks, and they cannot clear airways and manage those secretions earlier So that's going to be of concern of why we're going to get a lot of upper respiratory infections, and we're going to want to stay on top of that. Must be viewed through developmental lenses, again, a little more so than adults. So you're not going to speak to a 2 or 3 year old toddler in the same manner that you would an adolescent. That's the challenge of pediatric nursing, and what I think makes it incredibly exciting and fulfilling is my patient load can incorporate an infant, and in the very next room I can have a 17-year-old, and that keeps it exciting and different and challenging. For me, I feel that is, but some people find that challenging to the point that it can be somewhat cumbersome, because you need to be able to, can you have a therapeutic conversation with a 5-year-old versus a 15-year-old? It's very different. How are you going to educate them on a condition? If you have information that you need to transmit to them, maybe you're going to do it in the form of play for a preschooler. But for maybe an adolescent, you're going to give it to them in a form, demonstrate it, and then have them re-demonstrate it back to you to confirm that yes, they did receive that information. There's just different ways that you're going to go about that, and knowing those specifics are going to be important as they relate to the developmental stages that child would be in. More sensitive to many medications. Many meds are tested. They may not be tested on children, so we may be limited in the supply that we have access to. Dosing is critical. A very, very small error in an adult may be absorbed and not have tremendous outcomes or negative outcomes. It can be a small error in a medication or dosage for a newborn or a baby in the NICU can be catastrophic and even fatal. Therefore, that is one of the large, important aspects that you need to be aware of for pediatrics when it comes to dosage, are very weight specific. Children can get really, really sick really, really fast. But then on the flip side, they can get well very, very quickly. So they can, we refer to it as they can bounce back very quickly, whereas it may take a lot longer for an adult to bounce back from the same illness. And they are wholly dependent on the caregiver. So this is good if you have a very nurturing, involved caregiver. But on the flip side of that, we need to also know that they're very dependent on a caregiver. So what if that caregiver is abusive? What if they are not compliant with medications? They don't get the medications filled, or they don't ensure that the child is receiving the medications. They may delay seeking treatment, or there may be neglect. So seeing that there's a flip side to both. Risks at various developmental stages. You want to spend a significant amount of time reviewing Erickson's. There will be several questions that will relate to content from Erickson's that you're going to need to have a base foundation to knowing infant, toddler, preschool, school age, and then adolescent, knowing the age ranges that we have: infant, birth to 1 year, toddler 1 to 3, school ages generally, or preschool is 4 to 6, school age 6 to 11. Then as you're creeping into 12, 13, on up to typically 18 or 20, that starts to creep into young adult, but adolescent usually generally starts around 13. But know specifically, a lot of the questions tend to lean towards that infant stage up into toddler preschool. The questions that generally stay and are historic to the NCLEX, which relate to adolescents, is more so how would you convey information to them. And you would not choose, I would give them a staple 3-page type pages front and back and tell them to read and process that information. That is not what you would do for an adolescent. Whereas I alluded to earlier, you would offer a demonstration and then have them return that demonstration to you that could demonstrate an understanding of that information. Accidents are a number one cause of death, and injury prevention is key. Drowning, falling, choking, these types of things, motor vehicle accidents, not being in a proper car seat. This is going to be the case up through preschool age generally, but specifically infant to toddler. The most prominent cause of death is going to be accidental, which in most cases is preventable accidents. Consider teaching and health promotion needs at every age and stage, as I've mentioned. You want to, whereas again, if it's a toddler or preschool, you're going to want to play a game with them and educate them through play. And again, and as you move on up, adolescence more, these are the targeted two that I generally see the question, is why I'm referring that would be demonstration again for the adolescent. Consider teaching health at also adolescent specific to them. They like to work generally in small groups where they can feed off of each other and the attention is not solely on them. So if that's a possibility where they can link together and you all share this same condition, so there's that unity that comes in. The pressure is not solely on one person. They can work together and process through that information together and return demonstration for adolescents. So to the NCLEX, where textbook information is key in real life situations don't matter. This is going to be by the book, and you're going to typically, when these questions come, you're not going to think of, well, but wait, I know that's what the book said, but I saw a patient one time and I witnessed a nurse do this in one of my rotations. That is out the window. You want to think textbook. You want to think those cardinal signs that you have learned and that you have heard. You have witnessed it on a PowerPoint. You've heard it on a video. You've seen it. You read it in your textbook. It's repeated along. You've heard it in another course, and it continues to build. Those repetitions and those themes are the things you're going to want to remember. Uniquely pediatric conditions. What conditions or issues are seen specific to certain populations? Pay attention to those. What conditions commonly affect children that are specific to children? Most conditions, or a lot of conditions, can, let's say for the sake, asthma. Asthma can affect pediatrics. It can also affect adults. Want to look for those outliers of special considerations for the very young and the very old. Every PowerPoint that we generally do, there will be one slide that typically will address, these are the special considerations for the very young and the very old. So pay attention to those with reference to pediatrics. And so again, that's what you're going to see on typically on NCLEX questions. What impacts peds, or what presents itself during childhood that extends into adulthood? It's typically diagnosed in childhood. You can look at those things as well. So typically, let's look at something such as cerebral palsy. That's going to be identified and diagnosed very early on, and then it will extend into adulthood, but think about the different developmental stages as that transpires and what that looks like. Same with muscular dystrophy, those types of things, those types of conditions that are diagnosed early in generally infancy, or they start to notice for the case of such as muscular dystrophy or Duchenne's, they're going to start to notice that as they're coming in and the developmental stages aren't being met. That's going to be cardinal signs. And then typically in that toddler stage, as other children are sitting up or they're beginning to crawl and they're missing those, that's when that diagnosis will most likely take place. So common physiological childhood problems. These, just make note of these, and you can even go through each of these and just pull out one or two small things that are cardinal signs to these conditions. And these are the childhood conditions or abnormalities that are typically highly represented on the NCLEX, would be on this slide here. Let's see. So again, the biggest thing I can say as well, just in general with the NCLEX, is you know what you know. And you would not be sitting where you are right now if you are not capable of passing the NCLEX. You have passed so many exams. You have passed so many landmarks and hallmarks along the way of nursing school. You have the information. So take a deep breath, rest in that you know you're prepared, and go in well rested. Get a great night's sleep before. You're not going to cram anything in the last minute, but you want to have a clear head. So we have this cute little slide there. But childhood psychosocial conditions, we do look at the physiological, but just as much, and creeping up even more represented on the NCLEX now, ADHD, autism, basic eating disorders, and how does poverty affect children? How does that affect their conditions? Them starting out even as newborns, as feeding patterns. How does that look when you have a condition and it's not diagnosed till later? Different ways that poverty can impact a child. It can be a challenge of childhood. Abuse and neglect, and then suicide. This is a sad phenomenon that I see just when we have students in pediatric clinicals. We have so many that are on one-on-one suicide precautions. And why is that? What are some signs? What are some signs that they would need to seek help when they have a plan, for one, have a plan to harm themselves or others? But paying attention to these, not uniquely to pediatric as I meant, but that must be considered and are highly represented on the NCLEX. Pay attention to asthma, cystic fibrosis, diabetes, basic food allergies. Pain management is a big one, knowing basic pain scales and how you would interpret the pain level for pediatric clients. How do you assess pain on a newborn? They're not going to give you a pain scale, and they're not going to give you a scale, what are you from 1 to 10? That's not appropriate. So you're going to be looking more for grimacing and increase in vital signs. That's how you're going to assess pain in maybe a infant, whereas then you're thinking you may do the face scale for a preschooler, and through childhood, as we transition closer to adolescence, you can move into the pain scale from 1 to 10. So knowing age appropriateness for pain management, proper pain management. And a child cannot reach their optimal outcomes if they're in pain. So that must be addressed first and foremost. Immunizations, big one for the NCLEX. Review not only what immunizations that a child needs, but the points at which they need them. This is one, if I were you, the way I learned them, I just made a brief table and put the different stages, 6 months, year, at what year mark different things are, so you can get a visual for that. But immunizations are a big one, appendicitis, and then burns. And everything that I'm mentioning on here, typically on the NCLEX, they don't dive incredibly deep to something that you're not going to know. It's going to be more the foremost information and just the specifics that relate to nursing interventions and nursing care and consideration for these topics. So you don't have to take a massive 2-hour dive on each one of these. You just pull up, and if you look at asthma in 3 different areas, you pull it up, whichever you're comfortable with. Some people like to pull things up on their laptop. Some people want to dive into the textbook. Some people are just going to review PowerPoints. But get these conditions. Take this PowerPoint. Just jot down things that tend to be repetitive for these. But I'm trying to weed out some of the conditions. I'll have people, is this on the NCLEX? Is this? And anything is fair game. But again, what we're presenting here are the things that historically continue to be represented on the NCLEX. I'm going to give you some questions here. We're going to kind of run through these and just give a little shout out here. If you want to pause it, or if you just want to go through these and use them as a review, that is good as well. A nurse caring for a 1-year-old knows that obtaining an accurate pulse indicates which of the following. I'll let you look at that. And we actually, I have the letters on here, so you can either cover that up if you would like. But auscultate the apical pulse for 1 minute. That's going to be, so on here, I would get away all of the wording except for pulse of a 1-year-old and then 1 minute apical, 1 minute pulse, okay? Irregularities in rhythm are common among peds, so just know that. A lot of times that will freak people out, but there are abnormalities and they can be of concern, and then you realize it is just specific to their age, and then you can assess them, you know, a week or a month later, and they no longer have that abnormality. So it's a continual monitoring process in the case of peds. The apical pulse counted over 1 minute provides the most reliable data related to their pulse, their heart rate in a 1-year-old. And again, this is specific. We're talking about a 1-year-old, we're talking about an infant, and we're not talking about a 17-year-old pediatric client. When assessing a child's cultural background, the nurse in charge should keep in mind that behavioral patterns are passed from one generation to the other. We do not make assumptions, and cultural background has little bearing on a family's health practice. That is not the case. Physical characteristics, we're not forming any prejudgments. Heritage dictates a group's shared values. That can be the case, but maybe not. The key that you want to know about this is the behavioral patterns within a family go generation to generation. That's going to affect, because it's specific. You don't look at someone and assume their cultural background. You watch how their family interacts and what's passed down with that specific family unit. A family's behavioral patterns and values are passed. Cultural backgrounds commonly play a major role in determining a family's health practices. Physical characteristics do not indicate a child's culture, and although heritage plays a role in culture, it does not dictate a group's shared values. So again, specific to generation, which is familiar, family is going to be our cultural background will be derived from. While examining a 2-year-old child, the nurse in charge sees the anterior fontanelle is open. The nurse should, this is a 2-year-old. If this was a 2-month-old, this may be different. But for a 2-year-old, the proper answer, the most appropriate answer is to notify the doctor. Abnormal, notify the doctor immediately. This should close around 12 months, 12 to 18. It's one of the last to close, but by 2 years old, if it's still open, then that's going to be reason for concern. And our first response would be notify the caregiver. Sunken fontanelles may indicate what? A sunken fontanelle would indicate dehydration. Bulging, on the other hand, in closing may be due to increased cranial pressure within the head. So bulging, increased cranial pressure, whereas dehydration would be indicative of dehydration. Because the anterior fontanelle normally closes around 12 months generally, but for sure by 18 months, the nurse should notify the caregiver promptly of this finding. An open fontanelle does not indicate abuse and is not associated with Tay-Sachs disease. So that should help with that one. When administering an IM injection to an infant, the nurse in charge should use which site? So rule out all the information that we don't need. We're looking at an IM for an infant. So those are the key things, key components of this question. And we're going to look for D. We're going to look for the outer thigh. And you know, vast lat is how I remember this, is outer thigh. So the outer thigh, just think about, in this case, we know we're going IM, we know we're going deep. Let's go for the biggest. So even if you didn't know that, just kind of break that down and think about it. If we're going in deep, let's go for the biggest muscle that we can get. So that would be D. The nurse is aware that the most common assessment finding in a child with ulcerative colitis is, this would be B, bloody diarrhea. And it's, you know, the inflammation and bowel disease, so we're looking at bloody diarrhea. Let's see, increased abdominal cramps and abdominal distension are more common, would be more specific to maybe Crohn's disease. But ulcerative colitis Keywords, assertive colitis and then bloody diarrhea would go together. When developing a plan of care for a male adolescent, the nurse considers the child's psychosocial needs. During adolescence, psychosocial development focuses on B, establishing an identity. So again, if we didn't know this, we would break this down and our mind should immediately drift back to Erik Erikson's stages of development, and we know that they are trying to establish their identity for adolescents. According to Erikson, the primary psychosocial task during adolescence is to establish a personal identity. They can be in role confusion, or they can have a clear identity. And not that we ever have a total clear identity, but at least they would know who they are, and that's what they're searching for in adolescence. The adolescent attempts to establish a group identity by seeking acceptance and approval from peers, and strives to attain a personal identity by becoming more independent from their family. So they tend to drift a little more from that tight nucleus of that family and get slight independence and form their own identity. Becoming industrious in the developmental task of school-age child. Achieving intimacy is the task of the young adult, and then developing initiative in the task of a preschooler. So if you know Erik Erikson's and you know those stages, you would be able to answer this question and apply that. And again, when I read a question, I like to cover up the answers. I like to think through the process in my mind, establish what I think might be the answer, and then see if that is one of the answers that is offered. If it is, 9 times out of 10, you're going to want to go that one. You can review everything before you click to the next question, but go with your gut. When you're in this case of the NCLEX, go with your gut. Female child, age 2, is brought to the emergency department after ingesting an unknown number of aspirin tablets. About 30 minutes earlier, when entering the exam room, the child is crying and clinging to the mother. Which data should the nurse obtain first? This clearly, if you read this, you would know. If you're looking for your prioritization of nursing priorities, you would know. Always go for vital signs and make sure they're stable first. So heart rate, respiratory rate, and blood pressure. Recent exposure to communicable diseases, that is important, but not at this moment. Number of immunizations received, again, that would come down the road when you're taking history, but when we're thinking in the emergency department, this is not a high priority. Height and weight would come in the case of if we're about to administer with dosage calc. We're going to want to know that. But first and foremost, we're going to want to know if they're stable. So we're going to go straight to the vital signs. Always remember, heart and lungs top everything. Hannah, age 15, is 7 months pregnant. Okay. When teaching parental skills to an adolescent, the nurse knows that which teaching strategy is least effective. Least effective, okay, we know that's part of it, but right now the components we need to know of this question are, we have a 15-year-old and we're trying to teach education to a 15-year-old. What would you think of? Again, we said, I mentioned this earlier, demonstration. Support group, again, they like to work together. And then even audio visuals are going to be helpful. We are not, again, going to print off a pamphlet and a booklet of papers and hand it to them and expect that to be effective teaching, because it will not be. Again, when you're breaking down questions, note least effective. Don't skip over that in thinking, oh, adolescents, I know how they educate, and then look on here and find one and then grab it and then realize that the question said least. When performing a physical exam on an infant, the nurse in charge notes abnormally low set ears. This finding is associated with what? We know the low set ears are specific to Down syndrome. Nurse Kim is teaching a group of parents about otitis media. When discussing why children are predisposed to this disorder, the nurse should mention the significance of which anatomical feature? And that would be the eustachian tubes and the placement and the positioning. Parents bring their infant to the clinic seeking treatment for vomiting and diarrhea that has lasted 2 days. On assessment, the nurse in charge detects dry mucous membranes and lethargy. What other findings suggest fluid volume deficit? So if we're thinking dehydration, when you think dehydration, what would you be thinking of? And that would be what we mentioned earlier. A sunken fontanelle is indicative of a fluid volume deficit or dehydration. How should the nurse prepare a suspension before administration? By shaking it so that all the drug particles are dispensed uniformly. So suspension and then shaking. SIDS is one of the most common causes of death. At what age is the diagnosis of SIDS most likely? 1 week to 1 year of age, peaking at 2 to 4 months. Generally, this happens within the first year of life. When evaluating a severely depressed adolescent, the nurse knows that one indicator of a high risk for suicide is preoccupation with death. An adolescent who demonstrates a preoccupation with death, such as talking about death frequently, should be considered a high risk for suicide. Although depression, excessive sleepiness, and a history of cocaine use may also occur with suicidal adolescents, they can occur in adolescents who are not suicidal as well. So the preoccupation with death and people that are dying, or how people are dying, or just coming up with, ways of suicide could occur, or discussing. And a lot of times people will say, yeah, they would talk about stuff. I didn't realize that was a sign. But if they're to that point, that's going to be much more like with this. You could read this question at first and think, yeah, depression. If they're significantly facing depression, for prolonged depression especially, sleepiness, that can also contribute it. History of cocaine use, that's not ideal either. But again, when you look at the 4 responses and choosing the best one, preoccupation with death kind of stands out. I don't know if you can tell that when you look at those, but 3, none of these are ideal, but this one is very specific to suicide. Which of the following would be inappropriate when administering chemotherapy to a child? Observing the child for up to 5 minutes to note for signs of anaphylaxis. When administering chemotherapy, the nurse should observe for 20 minutes. So again, with this, for anaphylaxis, definitely 5 minutes is not long enough. So when we know that should be at least 20, we would know that it's inappropriate to monitor for 5 minutes and then leave. So, which of the following is best method for performing a physical examination on a toddler? From least to most intrusive. So we want to start in more of a playful manner, getting them engaged. We want to get all that taken care of, and then move in more to the invasive. Or you can even look at this in reference to more the private areas would come at the very end. You want to build up that rapport in a very safe zone where you can build up that trust and that rapport first. The nurse is assessing a newborn who had undergone vaginal delivery. Which of the following findings is least likely to be observed with a normal newborn? Heart rate of 80 beats per minute. And again, when we mentioned earlier, we need to know the vital signs. It's critical to know the vital signs for each range, be it a newborn, toddler, preschooler, school age, or adolescents. Know those norms so that you can identify the abnormal values. So we know an 80 beats per minute is going to be a warning sign, because normal is 120, can be up to 160, and that's normal. So the other ones would not be the case. Heart rate, 80 beats per minute would be the response for that question. At the community center, the nurse leads an adolescent health information group, which expands into the areas of discussion. She knows that these youth are trying to find out who they are, and discussions often focus on the directions they want to take in school and life, as well as peer relationships. According to Erickson, this stage is what? Erik Erikson's the stage. That's a lot of words, and it's purposely like that because all you need to know is adolescence and then developmental stage, according to Erikson, to know that identity versus role confusion is critical to that adolescent. The nurse answers a call bell and finds a frightened mother whose child, the patient, is having a seizure. Which of the actions should the nurse take? The nurse should clear the area and position the client safely. That is the first. And if you take a question, think first, make sure they're safe. If there's a response that indicates make sure the client is safe, you're going to want to, and that's more than likely going to be the response. So the nurse should clear the area and position the client safely. The client should be safe. The nurse is assessing a 9-month-old boy for a well baby check. Which of the following observations would be of most concern? The child does not sit unsupported. So again, if you know the developmental stages, know basically when a child would sit up, know when a child would stand up or be able to pull up, maybe roll over, when they can generally start walking. Because again, as I've mentioned, things such as muscular dystrophy, these types of things, when they start to fall behind on some of these milestones, sometimes it's the first indication when caregivers will seek help and seek health care. I noticed that Johnny is still laying down, and all the other children around his age and even a few months ahead are sitting up, and now they're starting to pull up, and Johnny still is laying flat on his back, or he's trying to roll over, and now they're taking their first steps, and we are behind. We're missing milestones, and obviously children are all unique. They all hit these milestones at different points on their journey. However, there are certain time frames that it should fall between. You notice almost everything we do will say it should close, Fontenelle should close between 12 and 18 months. Some people do it 12, some people may do a little later and be 18. And there's more of a range. There's more of a range of, they generally can sit up around 6 months. It may be 9 months. But now if we're getting a year, 18 months, and they're not, then we know that there is reason for concern, or we at least want to get it checked out, and then hopefully there's not a problem associated or a condition, and then they may be just a little bit behind, and we can get them that. Hopefully, maybe it's just they need some added resources, or it could be indicative of a certain condition that we know if we can get early interventions and we can get supported, we can support optimal outcomes for that child. But the longer we wait, we procrastinate getting treatment, then sometimes the harder it is to bounce back and support that child and that family. So the mother of an 11-month-old is in the clinic for her daughter's immunizations. She expresses concern that the child cannot walk yet. The nurse correctly replies that according to Denver developmental screens, the median age for walking is 12 months. Around a year old, they're going to start taking steps. This does not mean that there's a problem if it's a few months later. That does not mean that. It's just giving you a general range. And you can look at that Denver developmental screening scorecard to see that. Adolescent patient has symptoms of meningitis. The nurse knows to prepare for which of the following tests? Lumbar puncture. You can look through these. Let's see how we're doing on time. I'm supposed to kind of have kept this one within 30 minutes, but let's see this one. Age 13 has a lumbar puncture to examine the cerebral spinal fluid to determine if bacterial infection exists. Best position to keep her in after the procedure would be what? supine for several hours. And what will this help prevent? It will help prevent headaches. 12-year-old boy has fractured arm because of a fall off his bike. After the injury, he has been casted. The nurse knows it is important to perform all of the assessments on the area distal to the injury except. So we're going to be focused on cap refill, a radial and ulnar pulse, and finger movement. We're not going to be as concerned with skin integrity at that time because we're thinking circulation, just had a cast placed. Our focus is going to be on that circulation, getting to that extremity. So you can look at that Denver scale and you can see, let's see if I can pull this up. Yeah, you can look on that and you can see several other things. If you're around, if you babysit, if you're around kids, you can kind of gauge off of that. So if you get a question, just imagine, okay, let me think of someone that I have seen or I know, or even if it's in a restaurant and I saw and I think that kid was about this, what were they doing? Sometimes even that you can pull, use that information to help you. Normal vital signs, I have put a sheet in here just so you can kind of reference this. If you have an easier way, you can do that as well. But just know these ranges. Know what is normal and what is abnormal. And like heart rate, you can notice that as they get older, that will start to go down. Then once they reach the end of adolescence into young adulthood, then they have kind of stabilized into that adult vital signs. Same way as respirations, they're slowly going to decline. And then the reverse will happen. Here you can see with the blood pressure. And the ultimate goal is passing that NCLEX on the first try again. These were just a few things because NCLEX hits hard. They hit hard on developmental. I know most people will think it's going to be so much on the content and so much on all these lab values and cardiac and all these different things, and it is. But always note when you're going through, what were those things that just seem to be different, or where is the pain felt when it's an appendicitis? Just those specific things. Imagine a case scenario coming into the emergency department, and they say one phrase, and you being able to say, which quadrant is that pain in? Okay, then I know it's probably indicative of an appendicitis. These types of things where you don't need to know 2 pages worth on every condition, but just know 1 or 2 cardinal signs about the different ones that I have listed in here. Know the vital signs, know those ranges, know the developmental stages again of Erickson's. And these are another area that has not been typically represented as much, though, is mental health. Those psychosocial aspects for, even though it's starting to go younger, they still tend to put the questions geared towards adolescence. So know what that's like, that ideation of death and dying, and kind of an infatuation with that, and a discussion of that. And then whether it's ADHD, anxiety, all these different things that are psychosocial, don't forget that aspect as well. You're going to be looking at the physical signs and symptoms and conditions, but also look at that psychosocial. Don't leave that out. The last thing, again, developmental stages for what is happening when. And you might just look up developmental stages and kind of get a run through. We have the Erickson side of things, but I'm speaking more in reference to sitting up, pulling up, taking that first stage. Proximal distal development, that we know they're going to be able to from the inside out. So they can do a large movement of throwing a ball or slapping you in the face before they're going to work their way out distally and be able to pick up a penny or a small bead and put it into a cup. So that's proximal distal development. Also the cephalocaudal development. These are all typically on there just where you know this process, the developmental stages, where an infant will be flat down, can lift their head up. Then eventually they'll push up, then they'll sit up, then they can pull up, and then once they stand up, then they can begin to take their first steps. That is cephalocaudal, starting with their head and their movement. They have a big head that they're going to need to move proportionately into. So that's a big stage in there, is just being able to lift that head up. But cephalocaudal, proximal distal, those are things. Be generally aware of the primitive reflexes, which ones will slowly go away, because if they don't go away, that's also indicative of certain conditions and concerns. So we want to know certain reflexes will go away generally within that first year of life for that newborn through infancy. A lot of those are going to go away. So know what Babinski's is. So the different primitive reflexes that you'll want to look at. But general growth and development is going to be key, but just knowing basically those stages. If I can help in any way, though, we could obviously don't have time in this session to reteach all of these, but if there's something that you said, man, I just kind of struggled in this area and I don't fully understand something, or immunizations, there's going to be a question about immunizations. If you're going through that and you need help figuring out a way, I am all about figuring out unique ways to learn content. So if there's something that's just not sticking, please reach out to me and let me help. I would absolutely love to do so. Otherwise, I wish you well in the last week here of your classes, and I'm sad that it's over, but I look forward to celebrating you at pinning here in just a few days. But have a super rest of your week, and please reach out as always if I can do anything for you. Take care.